Good afternoon, and thank you for joining us for today's broadcast, My Beautiful Child, Spotlight Sickle Cell Disease and Congenital Disorders of Glycosylation, Research, Advocacy, and Strong Communities. My name is Derek Stevens, and I'm the Director of Marketing and New Product Development here at Emory Genetics Laboratory, and I'll be hosting today's webinar. I'd first like to acknowledge that this month is Sickle Cell Awareness Month, and that is why sickle cell is on our agenda as part of this webinar. We'd like to acknowledge that and celebrate it. I'd like to introduce our panelists for today. From the sickle cell disease community, we have Kemba Gossier. She is the President and CEO of Advancing Sickle Cell Advocacy Project, also known as ASAP, a nonprofit organization composed of sickle cell warriors, sickle cell trait carriers, caregivers, and those who have a passion to see a change within the sickle cell community. We also have Dr. Paul Braxton. Dr. Braxton is a former public school educator and now has committed his skills, education, and experience to advocating for warriors and families within the sickle cell disease community. Among our CDG panelists, we have Dr. Eva Morava. Dr. Morava is a professor of pediatrics, is a Cvg Care Medical Advisory Board member, and is a clinical biochemical geneticist at Hayward Genetics Center. We also have Andrea Berarducci. Andrea is the Cvg Care President and a community and parent representative. And lastly, we have Christie Smith. She is a board-certified genetic counselor who currently works as the Principal Scientific Support Specialist at NTD Labs, a laboratory that specializes in prenatal screening. One quick housekeeping note. We definitely want to encourage dialogue, and the attendees are all welcome to ask questions during the presentation. To do so, I've included an image here. You'll see a little chat box. You can type your question into the Type Question Here section, and then you select the person to send it to. Please send all questions to organizers and panelists. All questions will be answered at the end of the presentation. And with that, I would like to turn it over to our first presenter from the ASAP organization. Welcome, Kemba.
Hi, good afternoon, everyone. Okay. Is everyone able to see my screen?
Yes.
Okay. So hi, my name is Kemba Gossier. I'm president of I'll be presenting this presentation along with the history about our organization. We are a 501c3 nonprofit organization. We're a new organization. We were founded in 2015. Our organization is pretty much comprised of sickle cell disease warriors, caregivers, and those affected by sickle cell disease or sickle cell trait. And our name stands for Advancing Sickle Cell Advocacy Project, but it also is a play on the analogy ASAP. Because when you think of ASAP, you think of as soon as possible. And the sickle cell community needs is lacking in a lot of areas and needs help as soon as possible. Better treatments, better protocols. So that's the name of our organization, but it's also a play on that terminology as soon as possible. Our mission is to improve the quality of life, advocate on behalf of sickle cell clients, their families, and also serve as a voice for those who have no voice. We serve the sickle cell community, children that are affected, their parents. Just to give a little backstory myself, I am a carrier of the sickle cell trait. I was not aware that I was a carrier of the trait until my daughter was born, and she has SS, which is one of the rarest forms of the disease. So that's our mission as well, to educate the general public and people know how important it is to know their status if they are carriers of the sickle cell trait. Also, as a parent of a child with sickle cell, a lot of educators, teachers, schools aren't that informed on certain precautions that need to happen with kids with sickle cell. Like they need to have access to water, take frequent bathroom breaks. So that's something that ASAP is currently involved with, reaching out to different schools and educating staff. We have one champion that works with us, Dr. Gershwin Blyden. He's a medical oncologist in Miami, Florida. He is a champion for our cause and some of the things that we are doing. He speaks on occasion at some events that we have throughout the community with awareness and educating people on sickle cell. A lot of people aren't aware that sickle cell is one of the most common and one of the first documented blood disorders. However, we are behind. We only have one FDA-approved drug. It's been over 100 years since it's been documented, but we haven't come that far in terms of better treatment. Some of the things that we do, we conduct forums. We have a monthly support group that we run every fourth Saturday. We also do family events like picnics for the community, also the sickle cell community as well. We have wellness seminars that we conduct as well.
Transfer over?
Yes, and Mr. Braxton will be taking it over from here.
Well, good afternoon. Everyone still want to see my screen now, is that correct? So I will move on. One of the things that Kim spoke about was the importance of knowing about testing, immediate testing. Here you see the chart that gives the probability of having a child with sickle cell disease when you have two parents, each are carry the sickle cell gene trait. So they are what we refer to as carriers. They do not have the disease, they simply carry the trait. But by not knowing this, we are letting people understand, hoping people understand the probability of having a child with sickle cell disease, and it's outlined in this chart below. When we look at this, it's here you have 50% chance of your child, a child, just being a carrier, having one sickle gene from these two parents. So that's 25% chance that they'll have it on this configuration, 25% chance probability that they'll have it on this configuration. So that takes up 55% of 55 or 50%, I'm sorry, of the probability of your child's genetic outcome related to sickle cell disease. But there's also the additional 50 that remains. There's 50% chance or 25% chance, beg your pardon, that the child will have no effects, no genetic from sickle cell disease. And there's 25% chance that your child will be impaired with disease having the sickle cell trait genes, which would make that person a patient with sickle cell disease. This schematic sometimes confusing. They say, well, if we have 4 children, that's the probability of us having a child with sickle cell disease. This probability applies to each child. Every time you have a different child, the same probability sets itself up. So when we look at this next slide, we're actually getting a picture of what goes on with sickle cell disease, and people are asking what is sickle cell disease all the time. And that's simply a situation where a person has these particular anemia sickle cell genes. You see them there for sickle cell anemia. They'll have a 2S gene, hemoglobin. They'll have a S and a C, as you saw in the previous slide. And then there's also sickle beta thalassemia, which is a less strand, but can pose as many complications as the other two. Now, we see in the diagram below, and you can read through this on your own, you see in the diagram right that there is just a diagram of blood flow, vessels and arteries, whatever, and you see the sickle cell shapes here, and you see the normal red blood cells here. But what is going on here is there's what we call an event called the vascular occlusion crisis, where the cell, where after releasing the oxygen, the cell does not return to its normal flexible shape. It's the normal shape. You will see that actually what happens there is that there is a deformation of the cell itself, and it turns into a sickle shape. There's hard little rods that form within the cell after the oxygen has been released, not allowing the cell to return to its normal shape and size. These are also rigid, they're sticky, they're jagged, and they will not allow blood flow to pass. You see also in the bottom of that slide another graphic in that area. Moving to the next slide, we have some complications caused by sickle cell disease. These complications are always associated with a crisis over periods of time, some immediately, some stay a while, some move on. But the symptoms, as you see there are many, and we have laid them out there so that you can see the organs that are involved, as well as that this is a very serious problem here. And we go very rarely we think about children having strokes, but it goes on all the time. Yeah, headaches, severe headaches is a problem for them. We see here with the bones, this is also another serious problem that a lot of people aren't aware of, and that's vascular neurosis. And that's actually over a period of time of having these crises, vascular crisis. Over a period of time, we see that indicates that there's a breakdown, a deterioration of the bone, and it requires hip plates and other bones suffer as well. Here, infections are a big deal, and asthma is also part of that issue. The kidney, you'll see frequent urination. Well, the kidney is one of the what we call infection-dependent organs, and it's feeding over a period of time going from this process. As well, the spleen, abdominal pain associated with that. Most people, by the time they're in their early 20s, not everybody, but on the average, have lost their spleen. Eyes, you'll see jaundice, the yellow thing of the eyes, and skin. Also, the sad part is that it takes a period of time, but it can damage the optical nerve as well. And here, terribly embarrassing for young men, we see prior-pricking, and that involves the penis with unwanted, painful erections that happen to the child. You'll also see that it can be accompanied by some additional physical symptoms, anemia, and low exercise tolerance, susceptibility to infection, delayed growth, late onset of puberty. Again, that can be a real serious problem for a teenager, not only physically but emotionally as well. Decreased life expectancy, as we're happy to say. It's no longer a thing where most people are dead or dying at the age of 9 to 14, but we're on into our 40s, 50s, and 60s. Now, there's psychosocial impacts on patients with sickle cell disease as well. Where we see, that sometimes educators don't realize that there's academic risks for a student with sickle cell disease. They have cognitive and academic impacts. For example, there's strokes again. Learning skills are also a result of extended and long-term crisis involvement that people who are spending a life with sickle cell disease and periodically having the osteovascular crisis. IQ score as well has been documented. I'm sorry, I went too far on that. Next one is there's an emotional and mental health issues. Patients experience depression. Stress management is something that has to be in order to successfully live and enjoy a good ability to contribute to society. Mainly in school children, that's extensive absenteeism they experience, having to go to the hospital because sometimes it's crisis that it takes people to be, it requires hospitalization. As well, there's fear of crisis and fear of death that young people and older people have to deal with involving themselves in sickle cell disease. Some of the challenges that must be overcome. In particular, I could talk about these challenges in terms of the child making the transition from juvenile to adult health care. That can be such a stressful situation for not only the patient, but the parent, and I can imagine to a degree for the medical society itself. Those young people in transition, before that time comes, they need to manage their health care situation. They need to be able to identify insurance companies that are going to be willing to provide insurance for them. Also, there are local support services that are available to people, but if not trained or taught early, then they have no idea that some of these things even exist. They have to identify primary care providers because many insurances will not let you just deal with a specialist. And it's now requiring not only a primary care provider, but it's the kind of team, hematologists, nutritionists. A lot of people are coming together to deal with this issue crisis, to give that patient a good quality of life. And the development of employment skills. Because of the nature of the disease, that individual will not be working out in the sun or in snow over a long period of time because it's more likely to bring be an onset factor in having a sickle cell crisis or the osteodactyly crisis that we referred to before. So the development of employment skills is important, and work training should be done immediately. Education, are you going to go to training education, or are you looking to go on to higher education? And of course, developing an equal and mutual respect. And he's created to create an open and honest communication between patients and providers. That is something that we haven't experienced on a regular basis and a fair basis for up until now. Let's put it that way. Thank you very much for your time.
Thank you to our presenters. We definitely appreciate your time today and sharing more information about the Advancing Sickle Cell Advocacy Project. So my thanks to Dr. Braxton and to Kemba for presenting. Now we're going to change topics and move over to congenital disorders of glycosylation. And at this point, I will turn the presentation over to Dr. Moravo.
Do you see my screen?
Yes.
That's it. I'm honored to be part of this webinar and happy to talk about congenital disorders of glycosylation. This is an intriguing group of disorders. The impact on health is very significant because protein glycosylation is involved in protein folding, hormonal regulation, coagulation, endocrine and immune functions, and also in organ development. So patients have a very this condition. There are more than 100 different types, so it's really difficult to keep up the discovery of new types of CDG, and the clinical features are quite variable. Some of the patients have a profound neurological disease with multi-system involvement, and others are quite mild and have a great quality of life and function. I have to give you a little background about the glycosylation sugar chemistry. You see that for glycosylate sugars, and the little dots you see on the screen are different kind of sugars, like the yellow is galactose, the green round sugar is mannose. It seems complicated, but actually it's pretty easy to follow. You activate these different sugars, and then you have a lipid arm, which is depicted as, I'm not sure if you see my mouse, like a little yellow handle, and that handle grabs, add different sugars to the sugar tree, which goes through the endoplasmatic reticulum. It's branched, and at one point when glucose gets added to the sugar tree, are cut off from the lipid arm and get on the protein. It's almost ready, so it's already a glycosylated protein, what you see here, but it goes then for further processing to the Golgi. And here, as you see, some of the sugars get cut off, other sugars get imported to the Golgi and get added on to the sugar tree, and the final glycosylated protein is nice, colorful, and negatively charged glycoprotein with a sialic acid at the end. So that's how we diagnose the disease in blood. That's just one of the ways of diagnosing it, that we actually assay for the negative charge of glycosylated proteins. And if you take transferrin, for example, that's easy to run on the gel by isoelectric focusing. Then you see a normal transferrin has 4 charges, so you get on your blood a band at the 4 charged level. And if you are missing a glycan or negative charge and more of the 2 or the non-glycosylated form. If this is the situation when you have a disease in the ER, so the first part of the glycosylation process, most of the known CDGs are from this part of the biochemical pathway, but there are a few other patients from Golgi problems, and these are truncated glycans. So you see missing sugars at the end of the antenna, and you get letter-like pattern, so you can easily diagnose the 2 different types, type 1 and type 2. So when you have the diagnosis, the clinical presentation is amazingly diverse, and you see this washing list of different symptoms, from dysmorphic features to variable neurological involvement, cardiomyopathy, bleeding disorder, and at the same time a thrombotic disorder, because both anticoagulation and coagulation factors glycosylated, and skeletal, eye, endocrine abnormalities, feeding difficulties, chronic diarrhea, even the kidneys can be affected. Now you see with red letters the few symptoms which are not treatable, and if you think about it, most symptoms of CDG are quite well treatable on the symptomatology level. Unfortunately, the most frequent type, CDG1A, which is also called PMM2 CDG based on the genetic defect, is still not treatable, only on the symptomatology level. Patients have quite a recognizable face. They're very cute, but many times they have little subtle noses, little midfacial hypoplasia. Strabismus is very common, and a smooth spectrum, and they have rather large ears most of the time. They have neurological problems, developmental problems, frequently hypoplasia, cerebellar hypoplasia. And this really common disease is suspected to be 1 in 100,000, but most countries and most states in the United States only know about 6 to 10 patients, while we should expect to have like at least 50 PMM2 CDGs per state. The easy recognition is after birth, when you see these patients with feeding difficulties and the common abnormal fat distribution, the little fat pads around the hips. So unfortunately, still no therapy, but new therapies like enzyme replacement and substrate replacement are coming up in clinical studies pretty soon. So are there treatable CDGs we have to watch out for? Yes, definitely. There are more than 6 types which are fully treatable monosugar therapies, and there are several CDGs which are treatable by organ transplantation because they are monoorganic in their involvement. So what are these monosaccharide supplementation? Fructose and galactose, simple sugar, which we can apply orally in the patient's diet as a dietary supplement. So you see the list of disorders which benefit from the different sugars. And you see that the different disorders are also clinically very different, with Mp1 Cdg or Cdg1b, which is a hepatoenteropathy. The second disease is an immune disease, and the galactose-treated disorders are usually skeletal involvement, hypoglycemia, and seizure disorders. So watch out for these disorders because they are treatable with sugars. Here is a good example, Cdg1b, which is a severe life-threatening disorder, diarrhea, liver disease, and hypoglycemia. These patients get monotherapy daily, and their liver function and coagulation and diarrhea normalizes on treatment. This is like magic. After a few weeks of monotherapy, they have no symptoms anymore. However, in long term, unfortunately, the liver disease can be progressive, and some of the patients develop liver fibrosis on therapy, and they would need a transplantation in adult age. Another treatable condition with sugar therapy is Mp1 Cdg. I really want to emphasize this one because it's easily recognizable. In this disorder, the block is between glucose 6-phosphate and glucose 1-phosphate, and filling up the activated sugar pools with galactose restores the glycosylation problem and rebuilds the antennas, which are missing in the patients. So these patients have not only the common symptoms of glycosylation disorders like hypoglycemia or hormone problems, bleeding disorders, cardiomyopathy, they also have cleft palate at birth. So these are recognizable because they are born with congenital abnormality. And here you see the wonderful results like restoring coagulation and anticoagulation factors on galactose therapy, normalizing growth factors on galactose therapy in these patients. Only in a couple of weeks you get normalization of several blood parameters and improvement of liver function and hypoglycemia. So this is a very efficient treatment, adding just galactose to the diet. In 18 weeks you have restoration of most of the biochemical abnormalities. And finishing up with these two other disorders, which are seizure disorders, and you see the transferring pattern normalizing on galactose therapy. Even more importantly, these patients with severe seizures in these two types of CDGs improve in 2-3 months on therapy. So what are the other options? The other options are organ transplantation, and I just gave a few examples for successful transplantation of heart or liver in several types of CDGs, and more is coming up. So it's really important to recognize CDG in an early phase in order to help these patients and improve their quality of life. Thank you for listening.
Thank you, Dr. Marama. And we'll turn it over now to Andrea from Cvg Care.
Great. Okay, can everybody see my screen?
Yes.
Okay, great. So Cvg Care is the USA nonprofit patient group for the group of disorders, congenital disorders of glycosylation. I am the president and founder of Cvg Care, but most importantly, I am also the mother of a 6-year-old little girl who was diagnosed with Cdg1A at the age of 13 months old. As with all rare diseases, genetic disorders do not have any geographical boundaries. So we have about 1,000 cases of CdG that are diagnosed globally. So our organization collaborates with several international nonprofit associations in order to expand our impact and our effectiveness of our education and research efforts. Cvg Care was actually established in 2014, so it's a relatively new organization. I just want to give a little bit of history that prior to Cvg Care, patients and medical professionals found support for CDG education through the nonprofit called Cvg Family Network. And so what happened was around 2012, myself and a group of parents were talking with the administrators of the Cvg Family Network, and the decision was made that after serving 18 years of committed leadership to the CDG families, the network merged and transitioned its leadership over to our team so that we could pursue the process of creating a new 501c3 nonprofit, Cvg Care. So there's a lot of, we're still trying to get information out about our new website, and we just want to make sure that everybody knows that cvgcare.com is the new and active website, and that the old CDG organization is actually closed down its website, and all of its information has been turned over to Cvg Care. So the mission for Cvg Care is labeled out in this slide, but in short, it's to promote CDG awareness and to provide education and support to the families who are affected by CDG, and to advocate for scientific research to advance the diagnosis and treatment of CDG. Cvg Care has, its governance consists of 2 boards. We have a board of directors that consists of 9 members and a medical advisory board that's 8 members and always growing. Both boards are actively involved in prioritizing our initiatives, strategically identifying opportunities for growth, and collaborating with national and international partners to advance our cause. We have a current list of initiatives. They're growing. They change a little bit, but I really wanted to share some of the initiatives that we are currently working on. First of all, we have our website, which we work hard to keep it current and active with educational opportunities, resources, and upcoming news and events for our community. In 2016, we established May 16th as the first officially recognized CDG Awareness Day. We received signed proclamations by 5 state governors, and building upon that success, one of our international partners submitted an application to the World Health Organization to request that May 16th be recognized as World CDG Awareness Day for future years to come. So we look forward to hearing about that in the next 1 to 2 years if that request has been granted. We also have a semi-annual e-news that includes educational information, initiative updates, and progress in research and identification of new subtypes of CDG. As Dr. Marava shared, over 100 different types of CDG. The list continues to grow, so we try to keep that information current and available to families and medical professionals. Also, Cvg Care collaborates with the Rare Common Project out of Barcelona, Spain. We promote the enrollment of USA families and clinicians to participate in a CDG Global Clinical Patient Registry. And our most effective tool for increasing education and awareness among families and professionals is that we hold a USA CDG Family Conference every 2 years in the even-numbered years. So we had one in February of 2016, and we're planning for the next USA conference in 2018. And Cvg Care also actively participates in the planning of the World Conference on CDG, which is held in Europe, also every 2 years in the odd-numbered years. Fortunately, both of these conferences have been able to video record their conference sessions and make it available to families and medical professionals through the development of post-conference video educational series. And then our next upcoming event that we want to make everyone aware of is that we have the 3rd World Conference on CDG for families and professionals. It will be July 15th to the 16th, 2017 in Leuven, Belgium. I also want to share that we assist in the administration of a private and unique social networking group on Facebook, which is called Cvg Global Alliance. Through this platform, patients and families can seek compassionate support, share information, raise awareness, and build trusting relationships with other families and dedicated experts in the field. It is a closed private 50 members, I think it's actually 655 as of today, who are either diagnosed with CDG or a parent, grandparent, or sibling of a family member affected by CDG. And members also include CDG medical experts and professionals who serve the global CDG community. I just want to thank Emory Genetics Laboratory for allowing Cvg Care to participate today and to share with you a little more about our organization, our educational resources, and the services that we can provide families and professionals to create a stronger community for CDG. Thank you.
Thank you, Andrea. We appreciate your presentation. At this time, we're going to move over to Christie Smith to present a little bit more information on Cvg Care. Christie?
Thank you, Derek. Is everyone able to see my screen?
I can see it.
Okay, perfect. Thank you. So I really do appreciate this opportunity to discuss CDG from our family's perspective. I am a licensed certified genetic counselor by training. However, my reason for presenting today is my family history and our family's diagnostic odyssey in finding a final diagnosis of CDG. So I am a proud aunt of an amazing 18-year-old nephew named Zachary and 17-year-old niece named Grace. I did get permission from my brother Eric and his wife Kate to be able to share information about the family, including their names. So as you heard previously from Dr. Morava and CDG is a group of about 100 rare genetic metabolic disorders, and I kind of took this into 3 steps. First, it is rare. There are about 1,000 diagnosed cases of CDG worldwide to date. However, there are probably many cases of CDG that are undiagnosed today. So it is probably a very underdiagnosed disorder. There is a large variability of symptoms as well as overlap with other genetic diseases. So the diagnosis of CDG can be a bit convoluted. It is genetic. Most forms of CDG are autosomal recessive in inheritance. Dr. Braxton reviewed this inheritance pattern when he discussed sickle cell disease. However, in autosomal recessive inheritance, just as a reminder, the mother and father are typically healthy carriers of the disease. And for each child, they have approximately of passing that condition on. Now, what's interesting about the most common form of CDG is the inheritance pattern. While being autosomal recessive, all typically results in about a 1 in 3 you would expect based on typical Mendelian genetics. This is also a metabolic condition. Dr. Morava went through the process of glycosylation, and this process, while quite complex, is critical to normal growth and development of individuals. And it is a process that involves over 500 different genes. Individuals with a congenital disorder of glycosylation lack at least one of these gene products. And depending on which gene product they're missing, it can result in an array of different clinical features affecting multiple organ systems. So, as I said before, one of the difficulties in diagnosing CDG is this vast clinical presentation. In addition, the severity and prognosis of CDG can vary not only among subtype of CDG, in which there are about 100 known forms today, but also among individuals in the same subtype and even among family members of the same family. In my family history that I'll be sharing with you in just a moment, that is a perfect example of having siblings that have clinically variable features from one another. Now, most forms of CDG do have a neurologic component. Not all, but most. So some common symptoms would be low muscle tone, seizures, developmental delays, intellectual disability. Other common signs and symptoms would be gastrointestinal issues, so frequent vomiting or diarrhea, ocular issues like strabismus or retinal degeneration. Feeding difficulties are also common with the associated failure to thrive. There are additional symptoms such as stroke-like episodes. So a lot of different symptoms can be associated with these subtypes of CDG. I did call out two particular subtypes. CDG, one of the interesting things is the naming convention for each of these subtypes has changed. Initially, you often would see CDG dash either 1 or 2 followed by a letter. So CDG 1A is that most common form, of which over 700 cases have been diagnosed worldwide, and that accounts for about 70% of known cases of CDG. But that naming convention has changed with the identification of the specific genes involved in that particular form of CDG. So now the naming convention starts with the gene name -CDG. So in this case, PMM2-CDG. They are the same, but depending on when you're reading about the condition, it may be called either PMM2-CDG or CDG type 1A. Now, one of the references I read said that although if you look at the presence of the condition, it is quite rare, there may be an incidence closer to 1 in 20,000. The spectrum of symptoms is very wide. We discussed that in CDG there can be a wide array of symptoms and quite variable in this case, from fetal high drops to a severe infant form to only a mild adult onset condition. So huge variability even with the same subtype of CDG. I also mentioned CDG1B, which is also called Mp1 Cdg, and this is one of those conditions Dr. Morava talked about that does have a known treatment available. This is also one of those subtypes that does not have the typical neuro component. Now, in terms of treating CDG, and I'm not talking about using monosaccharide oral treatments like in the last subtype I mentioned, but in terms of treating the symptoms, it does require a team of specialists, pediatricians, neurologists, surgeons, cardiologists, and the list goes on and on. Depending on the symptoms present, there can be a wide array of different treatment options, from nutritional supplementation to ensure high caloric intake, to G-tubes so that they can have that proper feeding, occupational, physical, and speech therapies, anti-seizure medications, etc. So there is a wide array of treatment that can go along with the diagnosis of CDG. And if you look at the medical literature, CDG should truly be considered in any child with severe seizures and failure to thrive or any unexplained neurological syndrome. And there is a wide array of differential diagnoses for CDG. Many different genetic conditions can overlap the CDG spectrum. And I really like this quote from Dr. Fries in 2013. Inherited human glycosylation disorders span a breathtaking clinical spectrum, impacting nearly every organ system and launching a family-driven diagnostic odyssey. When I read this quote, I thought, my goodness, he must be talking about our family, a family-driven diagnostic odyssey. And so begins our family history. ALG3-CDG-MD. To date, there are only 11 known cases worldwide. However, if you look in gene reviews, there are only 5 cases of this subtype of CDG described. The first, there were 2 infants with severe developmental delay as well as other symptoms. Another child with joint contractures, seizures, developmental delays. And the very last, 2 siblings had severe developmental delay, failure to thrive, microcephaly, hypotonia, and seizures. One with significant digestive issues and the other neurologically impaired. This is my niece and nephew. So meet Zachary and Grace. These are beautiful siblings. And I put in parentheses with CDG because their personalities, their being comes first. They are amazing children that have brought such a wealth of joy to our family. But we truly had a diagnostic odyssey, and we went through all the stages of grief and depression. And I'm going to go through our family history. For those of you not familiar with pedigrees, circles indicate females, squares indicate males. When you see a triangle with a P, that's a pregnancy. So in this case, my brother Eric and his wife Kate, they lost their first pregnancy early on for an unknown reason, and then they became pregnant with Zachary. Kate was adopted, and there is no access to her family medical records. However, Eric's family history, my family history, was normal to our knowledge. Our uncle died at the age of 4 in a motor vehicle accident. Otherwise, there really was no history of illness at the time. During the pregnancy, Kate had an abnormal prenatal screening test that indicated a very high risk of Down syndrome. In fact, that risk was greater than 1 in 25. So Kate opted to have an amniocentesis, which was normal, showing that this pregnancy, in fact, did not have Down syndrome. So they were relieved, they were thrilled. It appeared as though they were having a healthy baby boy. She did end up with what they called toxemia at the time. Now I know that that was preeclampsia, and had a very difficult pregnancy, but in the end delivered a very healthy baby boy that they named Zachary Edward. He had APGARs of 9 and was seemingly healthy at birth. He was also a very happy newborn. He had amazing smiles and just brought joy to our family. Very soon, however, within a few months, he began to experience significant feeding difficulties. You know, when I would babysit him, I thought, oh my goodness, I used to babysit all the time, and I was challenged feeding my nephew. They were challenged as well. We have some amazing pictures of food all over Zachary's face, and we just thought this was normal, being, the first nephew in the family. He also had projectile vomiting and started to have what the doctor said were simply startle reflexes. They thought Eric and Kate were just, nervous new parents, and it really was nothing. Go home, you have a healthy baby boy. But not, very far thereafter, he started missing his major developmental milestones. But our family kept thinking, this could be normal for Zachary, right? Now I wonder if maybe we were in a bit of denial, and certainly the pediatrician didn't help us with that. But when Zachary was only 6 months old, even though he had had some mild developmental delays and some GI issues, Kate found out she was pregnant again, this time for Grace. Again, her pre-risk of Down syndrome, this time greater than 1 in 10, for which she had a normal amniocentesis. She was told again, it looks like you're going to have a healthy baby girl. And Grace was born apparently very healthy, again with APGARs of 9. So at this point, Zach was only having very mild developmental delays and some feeding issues, and Grace appeared very healthy. But this is when the tide started to turn in our family. This is when Zachary started to experience significant seizures. He was diagnosed with epilepsy and partial agenesis of the corpus callosum. For those of you not familiar with that, that is the area of the brain that connects the 2 hemispheres. So if that fails to develop normally, it can lead to an array of symptoms such as vision impairment, low muscle tone, developmental delays, low pain perception, feeding issues, seizures, and on and on. That low pain perception is probably one of the benefits of that particular symptom of CDG in Zach's case. The picture I put on this slide is the reason I specifically pulled this out is this is a picture on my birthday. This is the last time I was with Zachary and was able to see him sit up on his own and be able to hold and shake maracas. He was a joy and just giggling and laughing with me on my birthday. When I went back to college, I was actually at the University of Michigan undergoing my genetic counseling education. Zach was only 1.5 years, and he had a I put 9-minute seizure. I think it was a 9-hour seizure. This resulted in a non-responsive state for Zachary, and he remained in that state for what seemed like forever to our family. Without even a genetic diagnosis at hand, he was given a life expectancy of only 2 years, and our family couldn't understand how this could be possible. No genetic diagnosis, yet only a few months to live. So this brought on a lot of shock in my family, and of course heartbreak. And then fear, because Grace started to show developmental delays, feeding difficulties, and seizures, and it was clear they had the same unknown syndrome. And this is when they had their first genetics evaluation, in which Eric and Kate were repeatedly asked if they were related, and they started having strong feelings of blame. In fact, friends who had healthy babies, when they would see Zach and Grace, they would tell them, well, I did everything right. I didn't drink in the pregnancy. I was very careful. I exercised. I was healthy. Again, feelings of blame that maybe they did something wrong. They were given their first of 6 suspected but unconfirmed diagnoses. In this case, it was Angelman Syndrome. Angelman Syndrome is a genetic disorder characterized by developmental delays, ataxic movement, neurologic symptoms, and happy disposition. It was characteristic of my niece and nephew, but it was clearly not what they had. Eric and Kate wrote letters to geneticists across the country pleading for help. They traveled from Rochester to Buffalo, to Syracuse, to St. Louis, Boston, and New York in search of answers. They needed an answer to know what syndrome was linking their children together. And they were so fearful, we all were so fearful that, like Zachary, Grace's smile would be taken away from her. This picture of Grace visiting me in New Jersey when I worked as a prenatal genetic counselor. She came with my parents. One of the last trips she was able to take without a nurse along with us. So I do hold this in high regard as well. So for 4 years, there were no answers, and various illnesses like common colds would place Zach and Grace in the hospital for weeks at a time. Kate became a full-time caretaker and advocate. She would never leave her children alone. This led to significant exhaustion, as you can imagine. She was a product manager for a marketing firm, and she had to resign to take care of her children. This also led to the burden of all the costs on Eric, high stress position. But at the ages of 5 and 6, they got their first diagnosis of Batten disease. Batten disease is a genetic syndrome associated with vision loss, developmental and intellectual disability, speech difficulties, and seizures, among other symptoms. Again, very characteristic of Zach and Grace. But when Eric and Kate attended a conference for Batten disease in hopes to meet their families in their situation, they knew immediately that Zach and Grace did not have Batten disease. There was a silver lining, and this is when everything started to change in our family. Dr. Donna Krasnovich from the NIH attended the Batten disease conference and saw Eric and Kate. Whether she saw their look of discomfort, whether she saw Zach and Grace and recognized something in them, she approached them and asked them to meet with her in private. And that led them to going to meet with her at the NIH, and soon led to the definitive diagnosis of CDG type 1D. The final diagnosis, the end of this diagnostic odyssey. It took 6 years to get a diagnosis, but our family finally had one. As Kate said, every parent hopes to get a diagnosis that is curable. That was the hope, not the reality. But this diagnosis was critical to Zachary's quality of life. It allowed them to better advocate for services. They now have at-home nursing care around the clock. They have physical therapy, occupational therapy, and speech therapy. Zach is homeschooled because he is so susceptible to illness, yet Grace is able to be integrated into school. It also allows them to improve and give them proper medical care. Zach and Grace can be hospitalized with a common cold. We're very aware when any of our children are sick not to bring them around their cousins. But by knowing this is CDG, that has been extremely helpful. One example is that something called hypoalbuminemia, it's very hard for me to pronounce. This is very common in CDG. Very low levels can lead to high stress in children with CDG, and that there's a lot of fluid accumulation. So even though their albumin levels may be normal, a transfusion may be all they need to get them back and to be discharged from the hospital. So that's something that with all the changes in physicians, they can recognize this. They're able to advocate for the best medical care for Zachary and Grace. Zach and Grace are their sister fighters. They have such kind souls and find joy in each day. They persevere against all odds. Anyone who meets Zach and Grace is touched by their spirit, and our family is so thankful for what we have. And we know we are all made differently, yet still perfect. As Kate said, it was a scary journey to embark upon, and one for which they did not choose. However, the rewards have been bountiful. Kate was adopted, and they really didn't want to take the chance of having a third child with CDG. A 1 in 4 risk was too great for them. The thought of prenatal tests was not something they were willing to do. They felt, although they understood why some families would choose that, they felt for them it would devalue Zach and Grace's life. So they opted to adopt a third child. This time an open adoption, for which they're in close contact with my nephew Jaden's mother. So they have Zachary, they have Grace, and now they have Jaden, and they are now a perfect family. Jaden said, the only, and I think this is so true, what Kate said, of Jay, I should say, is the only thing he is intolerant of is intolerance itself. Here are some pictures of our family. Zach and Grace are part of our family. And we have found great joy. They have brought us all joy and make us appreciate every smile, every laugh, and every major milestone. So here is my family today. That's Eric and Kate and their 3 amazing children. When they're out in public, oftentimes people stare. However, Jaden says, don't worry, they just haven't seen a perfect family yet. Thank you.
Thank you, Christie. That was a great presentation. And one of the things I liked in particular was when you introduced Zachary and Grace as beautiful siblings, and then in parentheses put with CDG. I think that's an important message that the My Beautiful Child likes to promote, is that all children are beautiful, regardless of the genetic status they are born with. At this time, I'd like to thank all panelists for sharing their personal stories and their expertise. Genetic disorders are individually rare, but collectively they are more common than many believe. At this time, I'd like to open it up to questions in our last few minutes here. I do see a few already. It looks like some of these could be for both organizations. So in answering these questions, if ASAP could go first, and then Cvg Care. The first question is, how does one get involved, either as a clinician or an individual a family?
And that was for ASAP. How one can get involved is we have our, you can go on our website. We have a form that you can fill out. Right now we have a few nurses that are a part of our organization that volunteer with our support group and other events that we have going on. So you can fill out that form and it goes, it sends off an email. So we're located in Hollywood, Florida also.
Great, thank you. And from Cvg Care?
Yeah, pretty much a similar process on our website. On the Cvg Care website, we have volunteers for different initiatives, for teams, for the newsletter, for conference planning. We also are always looking for a new medical advisory board member, and we have a rotating board of directors. So there's many different skill sets that an individual may have. We pretty much have a volunteer or a participant that could work in many different aspects. We also have a state delegate for each state, that they are the ones responsible for writing their governor in order to continue to keep our CDG Awareness Day active.
Great, thank you. And our next question, again for both organizations, and we'll start with ASAP. What is the biggest educational need?
Well, in terms of sickle cell disease, the need is exactly is in the area of testing knowledge. Many people who know that they have the trait. There is no symptoms associated with it, and has no long-lasting physical effect. So it's basically the lack of knowledge. So what we would recommend that the knowledge and education and testing is primary. That we reach out with first. Then, of course, knowledge of how to raise yourself and your time and support.
Thank you. And from Cvg Care?
This is Andrea. I think that for the education piece, Dr. Morava touched on and Christie touched on, there are so many families that may be undiagnosed or misdiagnosed. So a lot of education we try to promote to primary care physicians, to genetic counselors, to medical centers throughout the United States. We're trying to get our newsletter to every pediatric institution through the United States in order to just keep CDG genetic testing in that forefront and provide a lot of pictures saying that, I mean, just like Zachary and Grace, children look different. Children can look typical, they can look atypical, but trying to keep the diagnostic journey shorter and more accurate for families, and it takes both the families as well as the medical professionals to work actively toward that.
Great, thank you. And the last question, I believe, sorry, we have another question here on CDG. What is the life of the adult with CDG?
What is the life? I'm sorry, I don't understand the question.
I believe they're asking about quality of life or how that life looks for an adult with CDG.
Oh, I would say first that there are patients who are already 40, 45 years old with CDG who have a diagnosis of CDG since their childhood. So that tells already a lot about life expectancy that children get, you know, to adulthood and even beyond young adulthood. Many of the patients we know with adult CDG have a very good quality of life, especially for CDG1B, but also CDG1A, the most common form, can be milder. We have patients who are able to study, and we have patients who are having an IQ around 80, so they need some support in everyday life, but they can say most CDG1A adults are more handicapped, and they need either a wheelchair to get around or some support, but able to communicate, to eat independently, take care of themselves on some level. So absolutely enjoyable quality of life in the majority of adult patients.
Great, thank you. And I think our last question, I believe, probably relates to the fact that we shared many personal stories today of families. In your diagnostic journeys, and this can be open to anyone, was there anything that you, looking back, might have asked a little earlier to shorten that diagnostic odyssey? If someone suspects perhaps a congenital disorder of glycosylation, are there questions that should be asked sooner? I believe is where that question was going.
I'm not sure. This is Andrea. My daughter, I mean, it was just really unknowing. I say that, just like Christie stated, that the families don't know if it's their first child, and the doctors are saying it's just a little bit of a delay. My daughter was premature, so everything was attributed to, oh, she's just premature, and I mean, personally, I didn't push it because I didn't think it was anything besides being premature, but she was diagnosed fairly young, 13 months old. But I would just say I know a family with CDG that was just diagnosed with their correct diagnosis after 16 years, and so it's just to keep pushing, just like Christie's family did, keep pushing for, if you go somewhere and you know, well, that's not the diagnosis my children had, just pushing, go somewhere else and try and seek that correct diagnosis that's going to fit for your family, because there may not be a cure, but there is support, and there's other people out there who can relate to you in a way often closer than your own biological family because of the unique and special children that you share.
I would agree with that, Andrea, and I think just keep pushing. At the time Zach and Grace were going through diagnostic odyssey, if you will, there was very little known about CDG. There were not nearly as many cases at the time, so it was just pushing to find answers, to learn as much as they could, to get any little jewels of knowledge they could find to help Zach and Grace reach their best potential and have the best possible outcomes. So, it's hard when you're starting this journey because you don't have any idea where to go, but if you just continue pushing, to not give up, to know, if you know in your heart of hearts something's wrong, trust that.
That is also the case with sickle cell disease, where it's pretty much simple to diagnose for a parent or potential parent to test it. The problem comes with the training and how to deal with the child that has sickle cell disease, because there's so many factors that are involved, like all the other rare diseases. There are similarities between us, and there are differences between us that are very, very distinctive. So it's a matter of continually pushing parents, as those who would like to be parents and aren't sure, to find information out. Be involved with your community-based organizations that support diseases like sickle cell anemia, where we find that the more that we talk amongst each other, and this is probably the whole truth for most diseases in general, that we begin to come up with these practices and ideas that help raising these children that have problems with genetic diseases and improving the quality of life, not only for the child, mind you, but this also, as has been indicated earlier, to the family as a whole. Genetic diseases can be not only detrimental to the child, but detrimental to the family as well. So the constant seeking for knowledge and support and assistance is a necessity.
Great. Thank you, Dr. Braxton. And again, I would like to thank all of our panelists for sharing your personal stories and expertise today, and also our audience. We did have a little bit of audio technical issues on this webinar, and I do apologize for that. But I thank you for your patience, and everyone hung in through the end of the presentation. I think this was great content. Following the ending of this recording, we'll be circulating around a few resources from each of these organizations, and we thank you for your time, and please stay tuned for the next My Beautiful Child webinar. Everyone have a great day.
Thank you.
Thank you.
Thank you. Have a great day.
Bye.
Bye, everyone.